Morning, I'm Mario Preti, obstetric and gynecologist, oncologist at the University of Torino, Italy. First of all, I would like to thank Professor Vargas for the kind invitation. Thanks, Victor. And then we are going to share the screen. I start with our presentation regarding HPV and cancer of the anus, vulva, vagina, penis, and oropharyngeal cancer. We know that the global prevalence of HPV per infection is about 11%, with a peak in about 25 years in younger patients. In HPV 16 is the most frequent oncogenic type, followed by HPV 18. We know also that HPV genital infection prevalence is higher in men, but is less likely to persist than in women. And in general, HPV prevalence in men tends to vary less by age group with respect to women. And the detection is infection in men is influenced by sampling technique, anatomic site, and population study. We know very well this junction, the reserve cell where the HPV has the first infection in the cervical transformation zone, the basal cells of the columnar junction. But the starting of this long and winding road, the HPV entry and trafficking into the cell is not limited to cervix, but the epithelial tissue and stem cell as target for HPV infection in other columnar transformation region, in particular anal transformation zone, or where there are junction between lymphoid and epithelial component, in particular the tonsillar crypt. So to keep in mind this junction for the target of HPV infection. As a matter of fact, HPV is not only a problem of the cervix, but a lot of other anatomical targets are present. We are going to see them in the next slide. We know that the incidence rate differ for the different cancer. It also differs the HPV-related percentage of cancer. The highest in cervical carcinoma and the lowest in oral cavity carcinoma. And also the relation with HPV 16 and 18 cancer is highest in the oral cervical carcinoma and is about 70% in cervical carcinoma. And the last terminology in 2012 underlined the HPV effect in the lower genital tract, and this is well underlined in this study where we found, according to the literature, that women treated for cervical intraepithelial neoplasia showed a higher risk of vulvar, vaginal, and anal carcinoma, and our risk was showed as 12 folds, and in the literature reach 86 folds of the risk of vaginal cancer. But all the risk of vulvar, vaginal, and anal cancer in women treated for cervical intraepithelial neoplasia is higher in the literature. And in particular, when we found the precancerous lesion of this cancer, we can find that when HPV 16 is present in the cervical specimen, the risk increase for vulvar, vaginal, and anal intraepithelial lesions. So a risk higher, almost twofold or threefold, the presence of HPV 16 with respect of the absence of HPV 16. And we are going to see the first HPV-related not cervical carcinoma. It's anal carcinoma. And anal carcinoma is a rare cancer, and most of them are related to HPV 16 and 18. We know that, unfortunately, the 5-year survival is still low, And we have a double prevalence in female than in male, and the peak age is between 55 and 64 years, and almost half of them are not localized tumors. So the importance of early diagnosis. We know that the anal HPV infection is detected in both sexes, but there are prevalence with the highest prevalence in sex with men, and the anal prevalence among women is twice that among men have sex with women. And in our particular field, the anal squamous cell carcinoma is higher the risk, it's half, but reaching the highest risk of MSS men in women with high-grade squamous intraepithelial neoplasia, vulvar high-grade squamous intraepithelial neoplasia. So it's important to have this patient as a target of particular attention as HPV target. These are anal intraepithelial neoplasia grade 3, and we know how we can screen this patient. The first of all is to identify high-risk group, and of course the best method could be high-resolution anoscopy, but is cost expensive, complicated, and sometimes painful, and not suitable for lower risk population. Anal cytology and HPV tests are easy to perform and cost-effective in high-risk population. Of course, we have digital anorectal examination, and it can be a resource in poor community. Well, HPV testing has a very high sensitivity and good negative predictive value. And when we have cytology positive and HPV positive genotype, we have a very good prediction of anal intraepithelial neoplasia compared with cytology alone. And so women with abnormal cytology results or positive HPV 16 or 18 test need to be referred to the second level examination, high resolution anoscopy. And what about vulvar cancer? We know that the HPV related is less than 30%, and most of them are 16, 18 HPV related. The incidence is about 2 women on 100,000 people, and the peak age is 69 years, and more than 50% are localized. But we have to keep in mind that we have 2 different pathways, and the HPV related is not the major step. We have the not HPV related to differentiated VIN, lichen sclerosus, lichen planus, that have a mutation of gene, and HPV infection we have accumulation of mutation during time. This is a very interesting study by the Dutch school. We are now talking about the HPV pathway to the vulvar oncogenesis. We have younger women, usually with better prognosis, less recurrence, and less frequent progression. There are usually multifocal lesions. Easier to diagnose both clinical and histopathological by with the difference of differentiated VIN. Very difficult to diagnose both from clinical and pathological point of view. In our recent study, we demonstrated that HPV DNA P16 and HPV mRNA were simultaneous positive in less than 5% of vulvar cancer. So probably the percentage of vulvar cancer really due to the oncological role of HPV is less than what is shown in the literature. So less than the 30–40% reported in the literature. This is a recent study. This is the precancerous lesion, the typical HPV-related intraepithelial neoplasia with this multifocal lesion, and this is a high-grade squamous intraepithelial lesion in a pregnant woman. In particular, we have to keep in mind that periclitoral lesions are at risk for invasion. So we demonstrated in a paper that the involvement of clitoris bring the patient at 18-fold the risk of invasion with respect and not present of clitoral involvement. So we must be careful to the periclitoral area is examination in patients with high-grade squamous intraepithelial lesion. Vaginal cancer. Vaginal cancer is a rare cancer. Most of this cancer is related to HPV 16 and 18. We see that it's less than 1 per 100,000 women a year. And the progression of intraepithelial vaginal lesion to invasive cancer is about 5–6%. And the risk is higher for variant 3 with respect to variant 2. And so it's important, even if they are all high-grade squamous intraepithelial lesion, to differentiate the grade 3. It is important to pay particular attention in previous hysterectomy patient because the risk to progression of cancer is higher, as we have demonstrated in the literature. Vaginal intraepithelial neoplasia is not easy to diagnose for a colposcopic point of view, because vagina is not so easy to explore. We have to help with particular forceps, and not easy to take biopsy. Sometimes we need to give estrogen. It is demonstrated that the sensitivity of colposcopy is relatively low, but can increase after estrogen use, and so after estrogenization of the epithelium, so we can give a better chance to diagnose pre-invasive vaginal lesion. And the counterpart, male counterpart, the penile carcinoma. Well, penile carcinoma is less than 50% HPV related, for the most part to HPV 16 and 18. And is a rare cancer, and the prevalence of HPV infection varies from 20 to 60%. We have a lot of subtype, histopathological subtype of this cancer, and these are differently related to HPV infection. In particular, the most collected infection are HPV infection are for warty, baseloid, and warty type. We have to keep in mind that the penis cancer is quite similar to vulvar cancer. So we have the HPV and the not HPV related pathway, and the same the vulvar cancer. So the HPV dependent with pre-invasive and invasive lesion, and the HPV independent rising from lichen sclerosus, similarly to vulvar not HPV related cancer. So very difficult to diagnose the pre-invasive phase. Well, carcinoma of the penile intraepithelial neoplasia, we have in couple very low concordance of HPV genotype, less than about 25% of the couples are concordant for the HPV type. We have to keep in mind that in this study, for example, subjects naive at the time 0 will become positive to HPV by 48 months. But in this other study, chaired by Anna Giuliano, we saw that the median time of clearance is less than 1 year, and at 24 months, only less than 10% of male HPV infection were persistent, and was persistent particular infection of HPV 16. Less than 2% of men with genital HPV 16 develop intraepithelial penile neoplasia within the first 12 of 24 months of follow-up. And they are, for the most part, HPV 16 related. On the other part, we have that patient with HPV positive penile cancer has a better disease-free survival, and this is also demonstrated by the positive of P16 penile cancer with better disease-free survival with respect to HPV negative cancer, the same of oral cancer. And we are going to see that also for oral cancer is the same, that HPV positive cancer is a better prognosis. We are going now to the HPV oropharyngeal cancer. We have an incidence of about 10 cases over 100,000 people, and only the 10% are HPV related, but most of them are HPV 16, 18 related. Well, the incidence is about 10 every 100,000 people, and unfortunately the survival is low because the diagnosis is always at advanced stage, and the prevalence of the disease in male is about threefold the prevalence of women. And we see that the localized cancers is about 1/4 patients. So unfortunately, we have regional and distant disease in most of patients at the diagnosis. HPV 16 is well reported in this study, causes more than 90% of oropharyngeal cancer. And this is reported that about the 10% of head and neck cancer are HPV related, and is a heavy burden, in particular in men. But we have to keep in mind that head, neck, and squamous cell carcinoma are not all the same. We are a different anatomic structure from the lips to the tongue, to the hard palate, the oral cavity, and the oropharynx. We have in particular, we described the particular aspect of the junction, the lymphoepithelial junction of the tonsil, where HPV can have the first infection. So there are differences in oropharyngeal cancer, and we see that in particular the strongest association, the most consistent association is with tonsil cancer. In this study, more than 50% of the tonsil cancer were HPV related. These are aspects of tonsil cancer, HPV related. Also for oropharyngeal cancer, as for vulvar cancer, as for penile cancer, patient with HPV positive tumor has a better survival with respect with patient with HPV negative tumors. And this is confirmed by according to the P16 expression. Well, these tumors are diagnosed in advanced stage, and it's not like cervical cancer. There is no screening. So the question is a screening possible? There are no precursor reasons. We cannot identify the tonsillar intraepithelial neoplasia. We cannot biopsy tonsils. And so the surface, the mucosal surface of the oropharynx is a challenge to examine. And so we need to limit our screening to high-risk population, and in particular to men aged 50, 65 with multiple sexual partners. And if we screen all the patient positive for HPV DNA, we have a very low positive predictive value. So we need to screen a lot of people to find few cancer. And grouping the high-risk patient, we can have screening for secondary prevention and early diagnosis in HPV positive. We have to load the future. Probably in the future, we have biomarkers that can help us in prevention. Probably it's already demonstrated that HPV 16 E6 antibody seropositive has a high sensitivity and specificity for the concurrent HPV 16 positive of oropharyngeal cancer. And most importantly, this diagnosis can precede the cancer diagnosed by 5-15 years. We can follow better this very high risk group, because we know that older men are not target for the prophylactic HPV vaccination, but we know that probably in the future, vaccination confer strong protection against HPV infection, oral HPV infection too. And so with the bivalent, the quadrivalent, and the non-valent vaccine, we remove most of the causes of HPV-related oropharyngeal cancer. And again, thank you for your kind attention and for the invitation.